Good morning, and welcome to the 4th Annual CKF State of Coverage Policy Summit. I am Susan Jo Thomas, and I gratefully serve as the Executive Director of CKF of Indiana. Before we move into the program, please take a moment with me for our native land acknowledgement. It still applies, although we're in the virtual format today. Covering Kids and Families of Indiana recognizes the historical injustices and consequences that are well documented in the health and socioeconomic outcomes. We acknowledge the benefits that have accrued to those who resettled the region after the expulsion of the native inhabitants. We have flourished on land taken from the native peoples who called this region their home. We bear an obligation to acknowledge this history, create a public awareness, and repair relationships with American Indian communities and the land. Covering Kids and Families of Indiana recognizes the sacrifices of the tribes that once lived and thrived in this state. The Miami people, the Potawatomi people, and the Shawnee people, and many other tribes who were forced off this land. We honor them as we gather, work, play, and pray in this space. You may have heard me say that this is the 4th annual summit. From each of our first 3 summits, we have identified at least one issue or piece of legislation on which to focus. Last summit, you may remember that we did a deep dive into the Medicaid coverage for immigrants. We identified the 5-year rule as important. That rule, just for your information, is the rule that forces lawfully present residents to wait 5 years before they are eligible to be on the Medicaid program. All other Hoosiers can apply and receive benefits as soon as they're eligible, but lawful permanent residents have a 5-year additional waiting period. Breaking news. Just yesterday, Mark Fairchild presented to the Commission on Improving the Status of Children, and his presentation was to recommend that this rule be abandoned. The Commission voted unanimously to support rescinding this rule. 2 legislators have agreed to sponsor. Thank you, Mark, and to all of you who work to make sure these programs are aligned with our principles. Now, the reason that you signed in today is because we have lined up some awesome folks to talk with you today. And I hope that you will use chat or any other way possible to be active and interact with the keynote presenter and all of the panelists. One last housekeeping thing is that if you are licensed by the Indiana Behavioral Health and Human Services Board, there are 2 continuing education units available for you through the generous support of the IU School of Social Work, my alma mater. Now I am very happy and privileged and pleased to introduce to you the keynote speaker. Jennifer Wagner is the Director of Medicaid Eligibility and Enrollment at the Center on Budget and Policy Priorities, belovedly referred to as the CBPP. Please take it away, Jennifer.
Great. Thank you so much, Susan Jo, for having me. I'm really excited to be with you all today. So today I am going to talk about unwinding the Medicaid continuous coverage provision. This is going to be a very significant event. Many say the most significant thing that has happened since the Affordable Care Act implementation. And there's a lot of opportunity for advocacy. There is a huge risk of eligible people losing coverage and a lot of work we need to do in this area. So let's dive in. First of all, let's talk a little bit about background of what the Medicaid continuous coverage requirement is. This was passed as a part of the Families First legislation back in March 2020 when the pandemic was just beginning. And it prohibits states from terminating Medicaid coverage for the majority of enrollees for the duration of the COVID-19 public health emergency. The only exceptions to this is if an enrollee requests ending their coverage, if they move out of state, or if they pass away. So as a result, most people have been on coverage for 2.5, 3 years at this point. This continuous coverage requirement was a condition of the 6.2% FMAP bump. So the federal government gave states an increase in their matching percentage for all of their Medicaid caseload, except the expansion population, as a condition of keeping these folks enrolled. This continuous coverage requirement is tied to the COVID-19 public health emergency. So this requirement to keep people on Medicaid goes through the end of the month in which the PHE ends. This enhanced FMAP, that 6.2% extra in federal funding, goes through the end of the quarter in which the PHE ends. So the big question is, when will the PHE end? That's been the big question for a long time now. And there's lots of projections and ideas out there about when it's going to actually end. But let's look at where things stand. The COVID-19 PHE is currently authorized through January of 2023. It was just renewed recently. But the good thing here is that HHS has promised to give 60 days notice prior to the end of the PHE to give states a heads up to prepare and make sure that everybody's ready. So with that in mind, if you back up 60 days from that January 2023 date, we should hear around November 14th if it's going to be extended or not. If we get 60 days notice from the federal government, we know that the continuous coverage provision, the requirement will end in January, and the enhanced FMAP will end at the end of March. But if we don't hear anything by the end of November 14th, then we can assume that the PHE will be renewed once again in January and run through April. If it actually ends then in April, then the disenrollments from Medicaid will begin as soon as May 1st, and the enhanced FMAP will run through June. So there's been a lot of effort preparing for this, looking ahead to this, because it is such a significant event. But it's been very challenging because we've been preparing for a long time. But it is very likely that the end is near, and we're going to actually have to confront these challenges very soon. So what happens at the end of the PHE? Well, we typically refer to this as unwinding the continuous coverage provision. So we hear that discussed quite a bit. So at the end of the PHE, states are going to have to conduct renewals on all of their enrollees. Now, this is important because you can't act on something that you found out during the PHE. So even if there was some data match or something that indicated somebody might be ineligible, you have to do a fresh renewal based on current circumstances at the end of the PHE. But the good news is this doesn't have to be done all at once. States can take up to 12 months to initiate renewals. And they can actually take 14 months to complete it because of the kind of time frame that a Medicaid renewal takes. But this is going to be really challenging, especially for state agencies. They're going to experience substantial workload increases. One factor is the fact that enrollment has increased significantly due to the disruption caused by the COVID-19 pandemic, as well as this continuous coverage provision. Nationwide, Medicaid rolls are up around 25%. Saw some data from Indiana indicating that it's actually closer to 50%. That doesn't totally match with the CMS data, so I know there are kind of different nuances, but it's clear that in Indiana, you have a significant increase in Medicaid caseload. So you have state staff that haven't been doing renewals or haven't been acting on terminations for this long period of time. And then they have to start renewals again or start acting on renewals with this increased caseload. So it's really going to be a substantial workload increase that could have negative effects that flow down to eligible individuals. But what is this renewal process? How is it going to work? Well, the first thing is that the state is required to attempt an ex parte renewal. That means that they look at data sources and see if they can confirm ongoing eligibility without even contacting the client. If they're able to do that, they go ahead and renew coverage and send folks a notice that they do not have to respond to. But if they're unable to confirm ongoing eligibility using the data sources, then the state will send the enrollee a pre-populated renewal form. And they have 30 days to return that by mail, online, or by phone. That's the federal regulations, not necessarily playing out that way in Indiana, from my understanding. So that's something we'll dive into a little bit later as an opportunity to streamline things a bit in Indiana. So what's going to happen? A number of people will renew and continue to receive coverage. Great. But there are going to be a lot of folks that lose coverage. And we need to kind of think about these folks in three different buckets. So the first is individuals who are ineligible for Medicaid at the point of their renewal, but they have other coverage, employer sponsored or through a spouse or something like that. So they're good to go. They've got other coverage. They're fine. We've got another bucket that's actually ineligible for Medicaid, but they need to transition to the marketplace. They don't have other coverage. They may be eligible for low cost or no cost coverage on the marketplace. So we've got to make sure we facilitate that transition, that they know that that coverage is available and that they actually enroll. We have a third bucket of folks who are eligible for Medicaid, but they actually lose coverage for procedural reasons. Didn't return the notice, the state didn't process it, something happened. And even though they remain income eligible, categorically eligible, they're all set, they should be eligible, they should be enrolled, they lost it for some reason. So as I said, that green bucket, we don't worry as much about them. You know, they've got coverage elsewhere. But let's take first this yellow bucket of folks who are ineligible for Medicaid, but need to transition to the marketplace, likely because their income has increased during the pandemic. So how do we think about them? Well, the first thing to know is that there are transfers from Medicaid to the marketplace, to the FFM in Indiana, the federally facilitated marketplace. But the thing is that only cases that are actually found ineligible for Medicaid are transferred to the marketplace. So if somebody doesn't return a form or doesn't return verification documents or something like that, there is no transfer. So if you think of somebody who knows that they have higher income, but that they've been kept on Medicaid because of this provision, if they get a renewal form, they might not bother to return it. They might know, okay, my times on Medicaid is up. But because they don't return it, they're not going to be found ineligible and not going to be transferred to the FFM. So these procedural denials are not going to get this information, which is one of the problems. The other challenge is for folks who actually are transferred to the FFM, we've got to make sure that the notice language is clear, that they are clearly directed what next steps to take in order to enroll in coverage at the FFM. Now, some of you might know that previously when a case was transferred to the FFM, there actually was an application started on the marketplace on healthcare.gov that somebody could go and pick up and then complete. Our understanding is that that's not going to happen anymore. Which isn't the worst thing because that was complicated to kind of pick up your application. The pre-population was minimal, but now it's going to be a little bit of a clearer message. You're no longer eligible for Medicaid. You may be eligible for Marketplace. Go to healthcare.gov and complete an application. Now, we're hopeful that the folks at CSIO at the FFM, at the Office of Communication up there, are going to do some active outreach. If they know that somebody may be eligible for coverage on the Marketplace, phone calls, texts, mailing, etc., to encourage them to apply at healthcare.gov. But as we all know, this is a really, really confusing transition, a confusing set of actions that folks have to take. So there's going to be a huge need for assistance from community partners to explain what to do, to help screen and make sure that somebody really is no longer eligible for Medicaid and to get them successfully over to Marketplace coverage. But it's this third bucket, that red bucket from the previous slide, that we worry about the most. And these are the eligible folks who are likely to lose coverage. Because if you don't complete a Medicaid renewal, your coverage ends at that point. Well, why might an eligible person not complete the renewal? There's a lot of reasons because it's a complex process. So an enrollee might not receive the renewal notice. They might have moved. They might not have a stable mailing address. They might not understand the renewal notice and what action needs to be taken, especially if they were sent renewal notices before and didn't respond, but still got Medicaid because of the continuous coverage requirement. That's one of the kind of confusing points of how the rules are changing going forward, and we've got to make sure that people understand that. And finally, people might get the notice, but they might not submit information timely because of the complexity of low-income families' lives. On the flip side, looking at the Medicaid agency, they may not be able to timely process documents. We've talked about the huge increase in workload that's coming their way. Many agencies are dramatically understaffed and are struggling right now, even though they're not doing these renewals in the traditional way. So they might get behind and not process things timely, leading to loss of coverage. So HHS estimates that over 15 million people will lose coverage at the end of the public health emergency. Now you might say, well, yeah, they became ineligible during the PHE and were just kept on because of continuous coverage requirement. But their estimate shows that at least half of those who lose coverage are actually still eligible. So that's a big problem and a huge concern. And plus, we have to realize that if somebody loses coverage at renewal, they don't just say, guess I don't need health insurance and walk away. They'll often call the agency. They'll reapply. There'll be additional paperwork for the client and for the agency. The client might experience a gap in coverage, forgo care, miss prescriptions, and things that'll overall increase costs to the system. So this is a huge opportunity and something that we need to pay close attention to. So here's some more information from that ASPE study within HHS, the Assistant Secretary for Planning and Evaluation, really looked at coverage loss during unwinding. And you'll see here that the blue portion by age group shows the folks who are going to lose Medicaid eligibility. They are no longer eligible for Medicaid. So they're going to fall into that green or yellow bucket that we showed earlier. But this yellow portion is folks who are going to be disenrolled despite still being eligible. And what's shocking to me, I focus on this, I'm fully aware of administrative burdens and all this stuff, but 72% of kids who would lose coverage are going to still be eligible. That is shocking, that is unacceptable, and that's something we have to look at. So about 45% of everyone who loses coverage will still be eligible, but 72% of children who lose coverage will actually still be eligible. And the racial disparities are very stark here as well. We see from this chart that an estimated 64% of Latinos who lose coverage will in fact still be eligible. That is wildly out of proportion to other groups, and something to really pay close attention to. And you can see that other people of color will have a much higher disenrollment rate despite still being eligible compared to white individuals. So the racial disparities here are very stark and should prompt us to take some serious action here. So when we think about this, a lot of the cause of this disenrollment, especially for those who remain eligible, are administrative burdens. Okay? Safety net programs are full of them. You have to fill out complex paperwork, submit verification documents, dig up pay stubs, sometimes birth certificates, get documentation from your employer. There's all this documentation and paperwork required that is very burdensome and is one of the main blockers to eligible people not enrolling. And this burden falls disproportionately on people of color. We saw those estimates of how this is actually going to play out at the end of the PHE. But why? Why does this happen? Well, first of all, people of color are disproportionately represented in these programs. And so these burdens are going to fall higher on them as compared to somebody who gets health coverage through their employer, for example. In addition, people of color are more likely to work multiple or low-wage jobs. And when we think about how intense we are about verifying income for these programs, we need pay stubs. We need letters from the employer to say when your last paycheck was, or why your hours are going to be different going forward than they were over the holidays. All of this stuff falls disproportionately on people of color. The good news is that there are a lot of policies available that do reduce administrative burden and will keep eligible people connected to coverage. And we're going to go into these a little bit more in detail later, but things like 12 months continuous eligibility that prevents disruptions in the middle of a certification period, making sure there's accessible online services for people to complete what they need to do, submit the necessary paperwork, etc. Let's just reduce verification requests. There are tons of electronic data sources available, especially for Medicaid, that allow a state to electronically verify eligibility without requiring all this paperwork to go back and forth. And finally, improved communications with applicants and enrollees. How do we make sure that they get the information, that it's clear, they know what actions need to be taken? So with that in mind, let's talk about some possible streamlining opportunities. There's a lot of headlines, there's a lot of attention to these millions of people who are likely to lose coverage at the end of the PHE. And that's great, that's really important to bring attention to this crisis and this major issue that is coming up. But the fact of the matter is that massive coverage loss isn't inevitable. We shouldn't accept that it's inevitable. We shouldn't treat it that way. Next year, when people are losing coverage despite doing everything they're supposed to, when people can't get to a call center because there's an 8-hour wait time, when the offices are overwhelmed, we shouldn't say, oh, well, we knew this was going to happen, because it doesn't have to happen. There are a lot of proven strategies out there that reduce churn, which is people who lose coverage and then have to reapply shortly thereafter. They lessen burden on both enrollees and agencies, and they also improve program integrity. So some of these things that are available include ex parte renewals. That's what I mentioned earlier, where a state can look at electronic data sources to renew eligibility without requiring paperwork from the client. Now, Indiana, I see that has a great ex parte rate. From what they've reported to the Kaiser Family Foundation 50-state survey, it looks like they're doing a great job on this. I would encourage you all out there to kind of verify this and look at the data. When we talk about automated renewals, ex parte renewals, some states use these terms a little differently. Some states may look at the percentage from a narrow group within the Medicaid population. They might exclude folks who also have SNAP or the elderly and disabled population or something like that. So if the rate truly is as great as it's showing for Indiana, then they're in good shape there. That's the #1 way to reduce administrative burden and to keep eligible people enrolled. But I think that's worth just taking a look at and see what's going to happen going forward with that rate. There are also generally opportunities to streamline for the non-MAGI population. That's how we refer to the age, blind, and disabled. The Affordable Care Act substantially changed policy and procedures for the MAGI population, but oftentimes the non-MAGI population got left behind a little bit. And some of the older ways of doing business and the more paperwork-heavy approaches still apply to that population, which is a shame because this is a very vulnerable group. They're very needy of their healthcare coverage. And generally, they tend to have pretty stable circumstances. They often have Social Security income, low assets, and things like that, that we really have the opportunity to streamline eligibility and renewals for this population. For the folks who are not ex parte renewed and actually have to complete a renewal, we need to make sure that they have all avenues available to them. You know, if they get the form, fill it out and send it back in, that's cool. But they should also be able to go online and do it, or call into the agency and complete a renewal over the phone. From my understanding, Indiana does not have an online renewal right now. When you go into the case management functionality on their website, you can report a change or get a benefit verification letter, but you can't actually complete the renewal. And that's unfortunate. We know that not everybody would choose or be able to go online to renew, but for those folks who are able to, that's a really streamlined way to get the information over to the agency very quickly. It's also required by the federal regulations. It has been a requirement since 2014 that people are able to apply and renew online and over the phone. So that's definitely worth looking into. Obviously, the unwinding is likely to begin in the next couple of months, but we can think of different ways to do the online renewal. It could be as simple as a fillable PDF that's set up on the website that the client can complete and hit submit, and that then is transmitted over to the agency. That's one end of the spectrum. Could go all the way to a smart dynamic renewal thing that's pre-populated with information the agency has. But it's really important that this pathway is available, especially for people who don't get their renewal form or don't know until kind of the last minute that they have to complete a renewal. Similarly, telephonic renewals are required by the regulations. And it's worth checking on what the situation is in Indiana and how smooth of a pathway that is. My understanding is you can actually do it over the phone, but you still have to submit a wet signature. You still have to get a paper mail to you that you have to send back. If that's the case, that's really inefficient, and the state should just capture a telephonic signature. They can make a recording of you stating your name and your information, and that constitutes a signature and can get the renewal completed in one sitting. So that's great. There are also a number of CMS waivers, CMS being the federal agency over Medicaid, that they have offered to states. They've done tons of work putting out guidance, recommendations, information to states on how to minimize coverage loss during unwinding. And they've got some things to streamline income verification and asset verification and other things that are worth considering for Indiana. So one of the key opportunities in renewing Medicaid is looking at SNAP. SNAP tends to have more regular contact with enrollees. During the PHE, there were some waivers, but I know Indiana stopped using those waivers a number of months ago. And in general, SNAP is closer to back to normal, or the new normal, with regard to contact with enrollees. And so they're likely to have updated addresses and contact information. So especially with kind of your integrated system in Indiana, it's important to make sure that you're pulling that information over from SNAP and making sure that that Medicaid renewal notice is going out to the accurate address and someone's likely to actually receive it. Importantly, you can also use SNAP information for Medicaid renewals. For those folks in the audience who kind of dabble in both programs, you know SNAP is verified frequently, very intensively, and precisely. It's really a valuable data source, and it can be used for Medicaid. So one way to do that is when the state renews SNAP, they could actually renew Medicaid at the same time. Even if Medicaid's not due yet, they can do an ex parte renewal. They can renew it and push it forward 12 months. And if you do that at every point of contact for SNAP, there's a possibility that a Medicaid renewal never actually comes due because you're just renewing it every 6 months if you touch the SNAP case that frequently. In addition, when Medicaid is doing an ex parte renewal, they look to various data sources: Social Security Administration, quarterly wage data, the work number. Well, they also should be looking to SNAP. They can actually just pull the income information that's recorded on the SNAP case and use that as a data source. That's particularly valuable for cases that have income information that's not otherwise electronically available. So if there's self-employment income and it's been recently verified on the SNAP case, Medicaid can use that. Similarly, a private pension or something that doesn't show up in a data source. SNAP verified that. We know that they need that pension letter. They're very precise in their verification. So Medicaid can just leverage that information to complete the renewal. So in addition with some of that streamlining kind of processes, some of those behind the scenes things, it's really important to have effective communication with enrollees. The bottom line for that is making sure we have updated addresses. And there are things the state can do to gather that information. They can use data that's available from the U.S. Postal Services. If somebody submits a change of address to USPS, it can flow to the state through the National Change of Address database. If the state sends out a notice and gets returned mail, they should not be just canceling the case. If there's a forwarding address on that returned mail, they can use that. So they should be leveraging every source of information, including SNAP, to make sure those addresses are updated. It's also important to make it easy for enrollees to submit updates. A lot of states have had a big kind of campaign reaching out to folks saying, make sure we can reach you. So if somebody does need to update their address, how do they do that? Hopefully they don't have to call the 1-800 number and wait on hold for hours. Hopefully there's a simple form online that doesn't require them to log in. I know Indiana has some communication out to folks and encourages them to update addresses, but it does require that you log into your account and do that right now. And that might be limiting for people who struggle with that. I don't believe that works if you don't have a social security number. There are a few limitations to that. So is there a Google form that somebody can just use to submit address updates? Let's make it as easy as possible. Then, of course, there should be a public campaign about the end of the PHE and what to expect. Now, this is a little bit tricky because of that 12-month unwinding period, because of the fact that the renewals are going to be spread out over a year. So you can't, it's kind of hard to say, really important, watch for mail from Medicaid sometime in the next year. So it's kind of tricky to nuance that and make sure people know, some of the messaging that's been tested is the rules have changed. Watch for mail from your agency and things like that to kind of communicate to folks that things are different now and they really need to respond to anything they get. Of course, clear notices and forms are essential to let people know they need to renew, to make the forms as easy to complete as possible. If somebody is ineligible and needs to go to the marketplace, what does that notice look like? And do people catch that? Or is that buried at the end of a 6-page notice in small print? The website and online portals are key areas. As I mentioned, I think Indiana has some like a tagline up there right now on important information. So how is that going to change when we get 60 days notice? How are folks going to be kept up to speed on what's happening? And of course, navigators and community-based organizations are going to be key here. No matter how many notices the state sends or what they put on the website, many folks in the community are going to go to their trusted partners, trusted organizations for information. So we need to make sure that those individuals have the detailed information. What groups are being renewed first? When are the notices being sent? When is this all beginning? What do you do if you lose coverage? Things like that. So we need to make sure that that information is flowing from the state down to these agencies so they know how to communicate and best assist their clientele. Another key point of partnership is with managed care organizations. So these MCOs working with Medicaid often have more frequent communication with enrollees. They've been talking to them throughout the pandemic. They have updated information from them. So they may have updated contact information that they can pass to the state. Also, in many cases, have more ability to conduct outreach. We know the state is often overwhelmed and sends out a notice, but doesn't really have capacity to do follow-up calls or anything else to let people know that they need to renew. But the MCOs may have that ability, and they obviously have a strong incentive to keep people enrolled and on their plans. And so they may be able to supplement the state's effort with additional outreach. CMS has done a lot of work in preparation for the unwinding to really foster this cooperation and to leverage the power of the MCOs to hopefully minimize coverage loss. So they specifically said that MCOs can send updated contact information to the state. So if they've got information from the client about a new address or phone number, that can be sent over to the state and the state can update their files based on that information. Going the other way, the state can share a renewal file with the MCO. Say, okay, in the month of May, these are the folks that are enrolled in your plan that are due for renewal. And then the MCO can possibly call or text or do additional outreach to make sure that they know that their renewal is due and take the appropriate action. If folks do lose coverage, the state can actually share a file with the MCO with a list of those who lost coverage for procedural reasons. So those who didn't submit their renewal form or some supporting documentation. And the MCO can then follow up with them and try to reconnect them to Medicaid and get them re-enrolled. And for those who need to transition to the ACA marketplace coverage to the FFM, MCOs are able to assist with that. There's some confusion around like marketing rules and some conflicts of interest, but CMS has been very clear that they're not the barrier. They've really streamlined the way to leverage MCOs and their resources to help make sure people stay connected to coverage. So let's talk a little bit about specific opportunities in Indiana. And I've touched on these throughout the presentation. So the first is that ex parte rate. As I mentioned, it looks pretty good. If that's real, if that's the rate that applies to the whole population, you're in pretty good shape, but that's worth verifying. Online renewals is key. Unless I missed something obvious on the website, and the way the state has actually reported and answered some questions says that they do not have an online renewal pathway. That's really worth pushing on. Again, that's required in the regulations and has been for years. And let's say unwinding begins in February. Even if it can't be stood up by February, it can't be stood up till June, that's okay. You know, this unwinding period is going to be a long haul. And the fact is that actually there's going to be kind of a snowball effect. That first month, things will go okay. But the second month, you have the whole tranche of renewals you're working on, plus people who lost coverage the previous month who are asking questions and reapplying. The third month, you have the regular tranche there, plus 2 months of people trying to reapply and get back on. So the fact is that some of the challenges will probably build over time during the unwinding period. And so some of these improvements, even if they're not ready to go on day one, even if they don't come in until month 4, that may actually just be when the state needs an extra level of support and when clients need a new way to submit information if call centers are bogged down or something like that. Phone renewals, again, it's worth checking into how easy that is. When you call the main number, is there a option in the IVR that routes you to the phone number? Is there a dedicated number that gets you to the telephonic renewals? Is that communicated clearly to clients? And what is the signature issue? Can they do it over the phone, or do they actually need to fill out a piece of paper and send it in? How is Indiana leveraging SNAP information? Again, with an integrated system, that should be right there. It doesn't require a lot of data matching and more complex things with different systems. And are they using that as part of the ex parte to push forward Medicaid when a SNAP renewal is done, and in other ways? What is the policy for the non-MAGI population? Are we really leveraging the fact that most of their situation can be electronically verified and doesn't change very much? We want to make sure, especially that this vulnerable population is connected to coverage if they remain eligible. Has Indiana considered text messaging? We want to try to nudge toward the 21st century in these programs and communicate with clients in ways other than just paper-based mail. If people's addresses have changed, if they have unstable mailing addresses or living conditions, in many cases, they will have a cell phone. Now, there's no guarantee that the cell phone number that's on the case from a few years ago is still right. But how do we piece together these different means of communication to try to connect with as many people as possible? And there has been some concern around the TCPA, the Telephone Consumer Protection Act, and limitations on text messaging. But there was a ruling last year that said that states have sovereign immunity and are not subject to liability under the TCPA. So there are complications to actually standing up a text messaging system. But if you get pushback, if advocates are pushing for this and get pushback from the state that they're not allowed to do it, that's not correct. I would be happy to work with you to get further information out there about their ability to send text messages. And finally, feedback loops. When this begins, there are going to be bumps in the road. There's going to be confusing notices. There's going to be miscommunication. There are going to be some things happening, perhaps in some regions of the state. So what are the feedback loops? How are the folks on the ground gathering information from clients, from people with lived experience? And what are they doing with that information? Is that going back up to the agency? Most agency folks are really hard workers that are trying to do things the right way, but it's really difficult. These are complicated systems. And they may have 6 months ago thought they programmed the system to do X, Y, and Z, but something happened along the way, and it turns out the system is not sending that notice, or that notice was not changed as they meant to. And so how do you gather information from how this is actually being experienced on the ground and feed that back up to the agency so that they can make changes as quickly as possible? In addition, we need you all on the ground monitoring what's happening. This is going to be a major event, as we've talked about. We can't wait for the states to gather their quarterly data and send it up to CMS and for CMS to analyze it and possibly publish it. We can't wait 6-7 months to find out that things are going south or that there are issues happening. So how do we know right away to raise the alarm bells? And part of this is going to be contingent on understanding what the state is doing. So some states are taking the full 12 months, but what they're doing is they're piling the folks that they think are likely to be ineligible. Folks who have, aged out of coverage or different things. Obviously, you have expansion, which is great, but folks that they know are likely ineligible, and they're front loading those individuals. They're going to do the renewal for them in the first 3 months. That's fine, but we know that a disproportionate number of those are going to be ineligible. So if we know that's happening, and we see a steep decline in Indiana in the first month or two, we might know why that is. And then we'd expect to see it level off. But if the state is simply distributing the caseload over all 12 months, and there's a huge decline right away, that's cause for alarm. So this is going to be a very nuanced, long-term engagement that we have to do to monitor, look at the states, work with CMS, and do everything possible to keep eligible people covered. So there are some additional opportunities in Indiana that are not quite as associated with unwinding. The good thing about unwinding is that it's not a new thing. A lot of effort was made during the pandemic to stand up PEBT, or pandemic unemployment assistance. And then there were lessons learned, but those programs ended. And so that's kind of challenging. Unwinding in general is the things we do every day in Medicaid, the administrative processes and notices and everything that we focus on, but just at a much higher scale with a lot more attention. So the good news there is there's an opportunity. There's an opportunity to push for improvements that many of us have been working on for years, now that there's so much attention and there's recognition of the crisis. And there are a lot of ways to frame those improvements. It could be just in the context of keeping eligible people enrolled. It could be because of staffing resources. Many states are struggling with staffing, and this streamlining helps clients, but it helps states as well. It could be from that racial equity administrative burden angle. A lot of these things kind of come together and can be done to improve processes for unwinding, but improvements that will last well beyond that. But other opportunities to kind of streamline things and connect people to coverage in Indiana lessens the overall workload for the agency and the client and should be considered. So for folks who are eligible for coverage but not enrolled, there are some opportunities and some cool things happening around outreach. Some states are using tax returns, state tax returns, to identify individuals who do not have health coverage and connecting them to Medicaid. Now, actually enrolling them right in Medicaid using that tax information to streamline enrollment directly is a little bit complicated and nuanced, but there are ways to let people know that they may be eligible or to do some outreach to them to make sure that they understand their options. Similarly, opportunities to coordinate with unemployment insurance. If somebody signs up for unemployment, there's a chance that they're eligible for Medicaid. So that can go from one end of the spectrum that has data matching agreements and pushes information over to Medicaid to a simple notice or flyer in the unemployment office to let people know that they may be eligible. We've touched on continuous eligibility, but this is a huge opportunity to keep kids covered. When you apply for benefits, you usually get a 12-month eligibility period. But sometimes during that 12 months, something happens. The family might have a change in income. And if they report it or the state checks some data and finds it, there's a possibility that folks get cut off in the middle of their eligibility period. And sometimes that's also for procedural reasons. They're sent a notice or request for information that they don't get or reply to timely, and they lose coverage, even if they may remain eligible. So for kids, there's an option to have continuous eligibility for a full year, and there's also a continuous eligibility option for adults. And this is definitely the way Medicaid is going. We've got 2 states with recently approved waivers that have continuous eligibility for kids for 5 or 6 years. So we're really looking to say, okay, people are eligible, they're very likely to remain eligible, let's keep them covered and reduce burdens. Speaking of burdens, I know that Healthy Indiana has a lot of challenging things around premiums and the 2-tiered system and everything that can be very difficult to navigate. And there's tons of research showing that these burdens are costly to the state and costly to clients that miss out on coverage because of them, and that the premium collection generally does not offset even the administrative costs let alone the human cost of people not having coverage. So obviously that's a complicated one and pretty politically charged and all, but that's a prime opportunity for burden reduction. And finally, the stronger coordination with on-the-ground helpers through unwinding and beyond is essential. The state can only do so much, but I know there are so many great folks, many of whom are at this conference, out there working with people on the ground. And the more coordination there is, the more information sharing and feedback loops that are there, the better the process will work overall. So lastly, we've got a couple of resources here, and I believe we can send these slides out at the end that'll show you the links. But we at CPD have a number of papers on unwinding with best practices, discussion about the administrative burden and health and racial equity. There's the ASPE report that I mentioned that has that data around the folks who are going to be disenrolled, even though they are likely still eligible. CMS has tons of, as a homepage, has a page with all kinds of great guidance, webinars, information on unwinding and what their policies are. And finally, Kaiser Family Foundation has a really good study around the fiscal implications. So we hear a lot of pushback from legislators saying, oh, you're going to end the enhanced FMAP, but we still have to keep these people on for up to a full year. Well, this study shows that in most states, if you compare the cost of keeping people on to the enhanced FMAP and the money the state has gotten, in most cases, states have gotten twice the expense of keeping folks on. So I know it works complicated in the budget, and that's a little bit messy, but the fact is that the 6.2% FMAP bump was fiscal relief for states and has more than paid for this continuous coverage provision. So it should not be used as an excuse to cut people off as soon as possible. So with that, here's my information. We live, eat, and breathe Medicaid and unwinding right now. So if there's anything that we can help you with or a specific kind of TA to Indiana that we can be of assistance with, please don't hesitate to reach out. So with that, I will turn it over to Mark.
Thank you so much, Jennifer. That was so much wonderful information. And I feel like you already have studied Indiana better than some of us have been able to. So we really appreciate all of your work going into that. So before we get started, I just want to make sure that all of our attendees are aware that we will, in this panel section, we'll be going into some Q&A. So anybody that wants to use that Q&A function, on your bottom bar there, go ahead and type those in. We've got about a half dozen already in there that we'll go through and be walking through those as we can. But next up, we're going to transition over to our panelists. So I'll ask them to unmute and share their video. And we'll do some introductions as they come up and are available. We have a ton to talk about. Also want to just take a brief moment to thank last year's group. As Susan Jo noticed, that we worked with the immigrant population and some specific issues there. We're hopeful to see that 5-year immigrant coverage rule, hopefully in the next year, go through its legislative steps necessary to end that. And again, that would give a coverage option for specifically new immigrant children and pregnant women. So that came directly from this policy summit last year. And we'll be shopping some ideas today of possible actions going forward as we deal with the unwinding and everything that's going on with Medicaid right now. It's a very, very exciting time. So we'll be watching everything coming in. Please keep asking those questions. But first, we're going to start out with just some nice introductions of our panelists that have joined us today. So I'll be shouting them out one at one, let them give themselves a little bit of an intro, what they do, and some of their population they go with. So why don't we start with Erin Macy. Erin's joining us today. You want to introduce yourself, who you're representing today, and maybe kind of an initial thought of something that really stood out from Jennifer's presentation.
Sure. Yeah. First, let me say thanks, Mark and Covering Kids and Families, for inviting me to be here. I am, due to the COVID reshuffling and parent obligations, I'm wearing a new hat now, but it's nice to be back with old friends. Andrew and I were colleagues in the past at the Institute for Working Families. I am now serving as the Senior Researcher and Director of Advocacy for the Grassroots Maternal and Child Health Initiative. We are housed at the IU Fairbanks School of Public Health, And this initiative was launched about 4 years ago with support from Riley Children's Foundation to take an innovative approach to reducing infant mortality and improving maternal and child health outcomes. And that approach is to support women leaders in zip codes with high infant mortality rates as system change agents. They are the experts in the problems in those contexts, and we are here to really support them in making those changes. So thanks to their insights and the team's efforts, we now have 9 project areas. They are featured on our spiffy new website, and I will not go into all of them. That'll be just a little bit of a teaser to get you to go there. But I will highlight just a couple. One is a program supported by the State Department of Health called Mothers on the Rise. It is in response to one of our grassroots leaders' experiences of leaving incarceration with an infant and only a night in a hotel room as support. And through her experience and through the team's efforts, we now have an entire coordinated system of support for every mom and baby pair leaving the nursery unit at Indiana Women's Prison. We also are launching, and I have been spending a lot of time working on our new housing initiative. Grassroots leaders have been emphasizing since the beginning how important the connection between housing and health is. So we just received a large grant from HRSA to stand up a housing initiative. And I see Care Sources here. They're one of our partners, Adam Mueller from Indiana Justice Project, the Hoosier Housing Needs Coalition. So Andrew's been a part of putting that grant together, and many other partners. So those are 2 of our kind of 9 areas that we're working on. And through that work, I wear quite a variety of hats, grant writing, research, working with our grassroots leaders to share their stories, baking cupcakes for family meetings, working on computer skills, all kinds of things. One of the things that really stood out to me from Jennifer's presentation is just the burden of paperwork and the chance of really losing folks that are eligible for coverage and missing them along the way. I immediately flashed back to one of the very first interviews that I did with a mom. She was where I really learned about how burdensome paperwork can be. She had 3 kiddos, one of whom was diagnosed with cancer. And so she was having to cut back on work because she lived in a rural area. She had to travel with her child for treatment. So she'd be gone for weeks at a time. She's arranging care for her other kids. She's working with her employer to try to stay employed, but obviously having to take significant time off from work. And so kind of missed a renewal notice, came up against that deadline and was sharing I'm already asking my employer for so much. It's difficult for me to get pay stubs and things that I need, and ended up missing a deadline. And I think about, I understand that we need to have procedures in place to do renewals, but what a burden it was on this family that was already going through so much. And so many of our grassroots leaders and Mothers on the Rise participants have similar situations where they're dealing with a lot. And so to have to chase down paperwork and deal with these renewals is really significant. And I really worry about the impact there. But thanks again for having me. I'm grateful to be part of the conversation.
Wonderful, excellent. Emily, would you like to intro yourself next and kind of give us your initial reactions?
Having me. Thanks to Mark and Covering Kids and Families. It's great to join you all here today, particularly with an expert like Jennifer. My name is Emily Bryant. I'm the Executive Director of Feeding Indiana's Hungry. We're the State Association of Feeding America affiliate food banks. We have 11 members that collectively serve all 92 counties across the state of Indiana. And those 11 independent nonprofits work with about 1,600 local pantries and other agencies to help distribute food to folks who need it across the state. Our association, I use we a lot. It's a pretty small we, it's 2 of us. But we do our best to bring together our members so they can best work with each other The concept of how do we work together on these things? How do we provide space for our food sourcers to gather? How do we make sure that our SNAP outreach folks are all connected? We advocate on behalf of the food banks at the state and federal level, and that can look like a number of different things. Sometimes it's nonprofit issues, sometimes it's tax policy. Often it's the impact of programs that impact them directly. So a lot about the emergency food assistance program or the commodity food that our members distribute at the federal level. But we also advocate on behalf of the clients that our members serve. So we work a lot in all the nutrition program areas, TFAP and SNAP more than others, but we certainly engage on child nutrition programs, senior nutrition programs, and sort of all the things in between. So a lot of our time is spent educating the public, educating elected officials. I see Andrew's at the State House, kudos to you. But spending a lot of time talking to those policymakers and the administrators of those programs to see what we can do to bring folks together, to make programs work more smoothly, to make them more equitable, and to make sure that we're not providing any additional barriers to access for those programs. My aha moment to Jennifer's presentation was perhaps largely on the optimistic end, only because this is such a big deal. And so we have people, with the Medicaid All Hands group that's coming together, all of the folks that are on this call today. There's a really big opportunity as we go through this process to make sure that people are connected to their healthcare, that we can do a nice little checkpoint to see, are you connected to WIC? Are you connected to SNAP? Can we make sure that, if you're applying for this or you're recertifying for that, we get you connected in all those ways? It's something that, we've seen with a lot of the healthcare providers, docs on the ground, as well as insurers. I know CareSource does this, where they work to connect their clients or their patients to nutrition programs, whether it's a pediatrician pre-screening, asking food insecurity questions, or, when you're a member of one of the insurers and they have a little bit of case management to say, okay, so you're here, you should be eligible for these things, are you enrolled? And so I'm choosing to be optimistic today that we can use this as a big coming together opportunity to make sure that Hoosiers are accessing all the programs that they're eligible for, not just piecemeal.
All right, and I appreciate the shift to optimism there, Emily, because we definitely want to hopefully end today on that note as well. All right, so next up we have live from, looks like the quiet booth at the Indiana State House, Andrew Bradley. Andrew, you want to intro yourself and kind of give us some of your initial thoughts?
Right, thank you, Mark, and thank you, Susan Joe at Covering Kids and Families, for inviting me to be part of this discussion. I'm Andrew Bradley, I'm Policy Director for Prosperity Indiana. We are the statewide association for community economic development organizations. And scrolling through the attendee list, I saw some familiar names, some of our members. We have about 200 of those organizations statewide who are members. We're strengthening Indiana's communities. A large proportion of them, 2/3 or so, are frontline community-based organizations and service organizations. Another good 10% or so are public entities, cities and counties. And then we also have some individuals and private entities that want to be part of that conversation. Community economic development really spans a lot, but we focus a lot of our work on affordable housing issues, a lot on asset building and consumer protection issues, especially when it's in my sphere of the policy arena. And so, thinking about some of the presentation earlier, what really struck me is there's so much overlap in a lot of those issues that we work. And as Mark mentioned, I'm at the State House today. Happening all through today is the Indiana Housing Task Force. So when we're done here, I'm going to go over there and be able to sit in on that hearing. As Erin mentioned, Prosperity Indiana, one of the things we do is we convene some issue-based coalitions. One of those is the Hoosier Housing Needs Coalition. I'll be talking some about the work of that coalition and how it intersects with the topic today. But that Hoosier Housing Needs Coalition is actually at the table, literally named to the Indiana Housing Task Force. So one of our coalition members is on the stage up there and participating in those discussions. And that's really, again, what struck me about the presentation earlier is how much of the population of Medicaid enrollees and those who are going to be impacted by the public health emergency unwinding are some of the exact same folks who have been impacted by housing instability throughout the pandemic. And we'll talk about this later, but it's, it's Black and brown Hoosiers, it's low income renters, it's families with children. And these are the folks who've been most likely to be hit by evictions or foreclosures. They're also the same folks who are going to see a delayed reaction from the pandemic. So just as the public health emergency, once that ends, it's going to have a whole new wave of impact. We're starting to see that now with a brand new wave of evictions and instability because emergency rental assistance is winding down. Have a chance to talk about some of that. I'd also be remiss if I didn't mention another hat that I wear. I'm the volunteer board president for the Indiana Coalition for Human Services, which is a statewide association of nonprofit groups of human service organizations covering kids and families, and Feeding Indiana's Hungry are also members of that group. So that's another perspective on this, is what the public health emergency and the pandemic and economic disruptions have meant for the human services sector in Indiana. So again, thanks for having me here. Look forward to being part of the conversation.
Right. Thank you, Andrew. And just because I'm always remiss in introducing myself, for those of you that don't know me or that are listening in today, I'm Mark Fairchild. I'm the Director of Policy and Communications for Covering Kids and Families of Indiana. I'm also a member of the Indiana Coalition for Human Services. So if you're an organization that's looking for places to get involved and get active, Andrew or I would love to corner you on that discussion and get you involved. Well, my job is really much what you see today. It's bringing folks together, having these discussions, and try to turn it into useful action moving forward. So we're going to get into some of our questions. I'm going to be kind of going back and forth between some ones that we have set up that we want to make sure get asked, that we've thought of ahead of time. And then again, note anybody that's watching for an opportunity to ask a question, just throw that into the Q&A, and we'll make sure we get that in there as well. I did want to kind of bounce off of where Andrew left us there, talking a little bit about some of the population that they serve, what their risks are like. So I'd like to hear from everybody on this a little bit, specifically talking about what are some of the health and well-being risks that are commonly seen in the populations you serve, and what are the barriers they face that really keep them from accessing health coverage, but all these systems that we're talking about today, just so we can start framing maybe the right way to go in there and tackle this. So we can bounce back to Erin, if you want to start with some of the things that you see, some of the unique risks and some of the unique barriers.
Sure. So clearly our population of interest is pregnant individuals, moms, and babies. As one of our grassroots leaders puts it, the very foundation of society and human existence, like a really important group of people. And she and I and another grassroots leader have been working on a project called Ask the Women. So we've been conducting interviews with women in different parts of the state about supports they had or wish they had while they were experiencing pregnancy. And from that, we have learned there's a really diverse experience of support during pregnancy. And it's really brought to the forefront some of the stories of the groups that we know really experienced challenges during this time. So I will highlight just a few of those groups. We know in particular, Black women experience much higher rates of maternal and infant death. They are navigating systems where they experience a lack of support both within and outside of healthcare. So that's a very important group to pay attention to. For rural women, the distance to care can sometimes be a really significant barrier. Some of them have also expressed feeling like providers kind of give up on them and their babies. So again, like some real significant challenges in terms of the healthcare that they receive. Teen mothers deal with a lot of stigma and fear. They may not seek healthcare because of those things. There's also lack of knowledge. We're not a state that requires comprehensive sex education. And so if these things aren't talked about, it can be really difficult to reach out for support or to know what to do. We've talked with women who don't have legal status here, didn't get prenatal care because they were blocked from healthcare access. So that's another group that we're concerned about. There are women who are really blindsided by a pregnancy, and so that can create some challenges in terms of their employment situation or not being connected to healthcare right away. So I think there are definitely several different populations that we need to be concerned and thinking about in terms of healthcare and healthcare access.
Absolutely. So let's see. Emily, what about some of the unique things that you're seeing with the population you serve?
Sure. So what's been interesting about food insecurity data, which is sort of the metrics that we have for the most part, is, believe it or not, they stayed stable from 2020 to 2021. I will definitely say that I do not think that will be the case for 2022. I will definitely say that is still way too many Hoosiers. Across the country, it was not statistically changed from those 2 years. And in Indiana, it actually went down a little bit, looking at 3-year averages. But we're still seeing a large number of clients coming through who are in need of food assistance, who may also be accessing SNAP or WIC or child nutrition programs, because with the economy and with inflation and the uncertainty of it all, they still need the assistance. And so, we're seeing people who are not just traditionally food insecure that are coming to seek help from the food banks and the pantries. The folks that we see and the things that we track as far as what their health issues are tend to run more towards the nutrition-based health issues. So we know that our clients have a tendency to have diabetes or hypertension and obesity. And so when we look at how we're serving them, we're looking at what we can provide them that will help with those or prevent those sort of things. And so when we look at, whether folks are accessing healthcare, it also can connect them to meal services, particularly seniors. If they're eligible for Medicaid, they're eligible for SNAP. How do we make sure they're getting to those things? And then the barriers we see with those are what you would expect for any human services program. The first is, can I get to that distribution? Do I have transportation? Do I have a refrigerator to put it in? Do I have the ability to go often enough to meet the needs of my family? We don't see as much fear as maybe in the healthcare scenario, but of course there are immigrants who have seen the chilling effect when we've looked at public charge and other things over the last few years. More than anything, I think it's still the stigma of whether you're asking for help. We had a conversation with a legislator yesterday who said, do all these people really need this? And one of my prior board members said, it takes a lot of humility to wait in line for hours to be given food that you don't know what it is, that's being given to you from someone in your community. And so I think a lot of people continue to avoid that help, at least from our members, because of that stigma. But I think it's become more out in the open with the pandemic. I've used in presentations the aerial photo from a drone of a food bank distribution in San Antonio, Texas. It was April of 2020, when pantries weren't open, nobody knew what was going on, and it was just back and forth across this parking lot. Right? People understand that it's out there. It looks differently now. It's the same number of people, if not more, seeking help. But they're doing it indoors or in lines across your community, not just the one. But I think knowing that that's out there and folks knowing how to access it has improved. But it certainly there continue to be barriers. If you don't have the resources to grocery shop at your convenience, to do it online, to place your WIC orders online, to do all these other things, there are still barriers to accessing the food that you need. And I think you see that in any population.
Absolutely. Right, Andrew, what do you have to share with some of the population you serve as far as just those barriers, those unique challenges, and some of the health risks?
Well, I'd start off by saying housing is healthcare, and having access to safe, affordable, and stable housing is literally the foundation for financial and economic and health stability. And so right behind me here at the State House, there was a classroom full of kids and their teachers and chaperones filing in for a tour. And I think, some of those are some of the populations that we've seen be most impacted during the pandemic, and where that connection between housing and health stability is important. Kids and low and middle income families are those that have been really impacted. We've seen statistics that show that families that have access to affordable housing, and kind of the standard for that is that housing is affordable if you're not spending more than 30% of your income on housing costs. Otherwise, you are cost burdened. So if you have access to affordable housing, those families are able to spend 5 times more on healthcare and about 1/3 more on food versus those who are severely cost burdened. And those are the families that spend more than half. The Center for Research, Outcomes, and Education has also found that for people who have access to good, affordable, quality housing, that they spend less on Medicaid costs. They spend about 20% more on primary care visits. They're able to spend that much more, but they end up having to spend 18% less on doctor visits, and then they end up having about 12% less on accumulated medical expenses. So again, having that stability of housing is really an underpinning that kind of frees up the ability to spend on other things. One of the phrases that's common in my line of work is that the rent eats first. So if you have to pay rent and you have to pay it in full, especially in Indiana, or else you are going to be subject to eviction quickly. And as I previewed a little earlier, we've seen that during the pandemic, Black households in Indiana, at 39.2% of those households have seen housing instability over the past year. That compares to only 19.6% of white households, and then about 35% of Latino households. Families with children have been about twice as likely to be subject to housing instability and eviction compared to households without children. And we've really seen it's low-income renter households that have really borne the brunt of this. And in Indiana, there have been over 132,000 evictions filed during the pandemic, and that is despite the availability, the ebb and flow of emergency rental assistance and all of the other pandemic-related housing programs. And when, from our organization and our Hoosier Housing Needs Coalition's perspective, it's because Indiana has had a pre-existing housing stability and affordability crisis compared to our peer states that really puts us out of step with the rest of the Midwest and many other states. And these are policy choices that cause this. So when you talk about that connection between housing and healthcare, when you don't have that stability of housing in a state like Indiana, then that means that those families and children are seeing those effects at a much more disproportionate rate than other states. So it's not a state of nature, it's a policy choice.
Excellent. And Aaron, I'm guessing you have something to add for that regarding some of the pregnancy outcomes and some of the work you're doing with a few of your special projects.
Yeah, I would just emphasize Andrew's point. I mentioned earlier that from the beginning, our grassroots leaders have really pointed out the connection between housing and health. And there are several large-scale recent studies really demonstrating that connection for birth outcomes. So one study out of California really examined this issue and found that housing instability during pregnancy is on a par with smoking in terms of the detrimental effects for pregnant women. And so I think to his point also, when one of the reasons we're excited to bring Healthy Beginnings at Home here to Indiana, which provides housing navigation services, tapered rental assistance, and housing case management to pregnant individuals for a 2-year period of time, is that the pilot program that was done in Ohio showed some substantial differences in NICU stays. Now, a NICU stay is really expensive. I know rent is expensive, but when we compare those costs, it's also an issue of spending smart, right? So by providing stable housing, maybe we can avoid some of these really like long-term and challenging costs down the road.
Yeah, very, very important to be looking at that population going through. So I'm going to segue into a couple of our audience questions because we do have quite a few piling in, which is great to see that interaction there. One, just so she knows we didn't forget her, I'm going to push back to Jennifer for a second, and see if this is what we're discussing so far and what you're hearing from our local folks really mirrors anything you've seen at a national level. And then we do have a specific question about what are some of the disparate impact risks that maybe you're seeing for the Hispanic population? I know there's a lot of concern specifically with that population and some of the workforce issues there.
Yeah, I mean, it's interesting to think about what the barriers are at renewal that are different from application. So when we talk about immigrant access and Latino access, we think a lot about public charge rule and the stigma and the fear and everything and why people might not engage with public benefits. And also lack of understanding that even if a parent perhaps lacks documentation that their child may be eligible for benefits. But what's striking about these data is that it's renewal. So people overcame that barrier and enrolled in coverage, but they don't keep that coverage. There's something that gets in the way of that. And so that points to communication, to language issues in a lot of ways. So how are the notices sent out and what is requested in return? We also think about verification. Everything in my mind goes towards verification issues and some of these administrative burdens, but sometimes individuals may be working different jobs that may be more burdensome to provide eligibility documentation for. But I think really the language and the outreach are key. Are the notices in multiple languages? But beyond that, what about the online portal? Is that easy to switch into Spanish and navigate? Is it effectively translated, or is it a Google Translate version that is very difficult to navigate? How about the phone? Is it easy to get services in Spanish, or do you have to wait a long time? So, I think we think of all those administrative barriers and those points of risk throughout the process and think how they're just elevated. They're just so much higher for Latinos and other immigrants and non-English speakers and the different barriers that they have along those ways. Again, solutions available, proven approaches that can help with there, but that's often thought of as extra. That's like, oh, someday are nice to have rather than essential part of a state's obligation to its citizens.
Very good points. Yeah, and anybody that uses Google Translate for their services would know. I think I made the mistake of assuming that would work okay on our website and all the jargon. Well, it's a good way to flag how much jargon you've got on your communications for sure. Is trying to translate it and understand that it probably didn't make sense in English, let alone in another language. So very, very valid point that we're seeing a lot going through there. So let's talk communication, because I think that's a good way to segue into that. Would love to hear about some of the strategies that we're seeing at a state level, some of the ways that you found, especially since we have some folks that are uniquely poised to be communicating with specific populations. What has been working to communicate with populations, and what do we really need to be thinking about doing better? Let's start with this time, Emily. So what's the communications that works with the populations that you've seen work, and what can we be doing better there?
I think it's a lot easier to look at things we could be doing better, because I think with the populations that we serve, and I think it's the same for everyone, they're hard to reach. They're more mobile, contact information changes. Jennifer's right, with SNAP, we do see them every 6 months. So it's been more frequently during the pandemic that we have had that the state has had touch points with them rather than with Medicaid. I think it's difficult for the state agencies to do this, and it's difficult to do it well. And so, we often look to what other states are doing. When the SNAP emergency allotments ended, there was a little bit of communication sent out, not a lot, and it was going to end one way or the other. When pandemic EBT benefits go out, And that's been a heroic lift for, I think, every state that's done it. And our folks have done a bang up job in spite of that not existing before they, they built the plane as they were flying it. But there's a lot of hard places to try to reach people and try to touch point, have those touch points. They're dealing with that same thing now with PBT because the USDA is requiring that homeschooled and online schooled children have access to PBT benefits, which is really great, but we don't know how to find them all, right? So there's all these, it's sort of the perfect conundrum of how do you find people we don't know exist? At least with folks who are enrolled in SNAP and Medicaid, we know they exist. We know they're out there somewhere. But if you think about sending mail to them, sending emails, doing phone calls, all these things, valid ways to contact someone who has that kind of stability, but those aren't necessarily our clients. And so one thing that we have tried to do and will continue to do working with the coalition and with Covering Kids and Families and with the other groups too is, we provide flyers as, pushing them out the door on SNAP eligibility, on SNAP changes, on whatever's going on as best as we can to our 11 food banks who share that information with their 1,600 agencies, just to try to get a piece of paper in front of a client. Now, there's a lot of different ways you can do that. And I have children, people, if they don't send me flyers home from school anymore since the pandemic, but that's real easy to get shoved at the bottom of the bag and you'll never see it again. And I think the same applies in these situations. I think if we're going to be honest about what is a really super effective way to reach people, it would be a very large, multifaceted communication strategy that is well above my pay grade to envision. We've done this from time to time with CHIP enrollment, with other things, billboards, buses, anything you can think of, radio ads. I think in order to really, really make sure we're reaching people in our world, and I think in others, is to find as many ways as possible to try to get to them. And that's hard. And, once we've got their attention, what do we do with them? My understanding so far with the enrolling is that they're going to direct all the phone calls to the 1-800 number that is actually the Division of Family Resources. It's not OMPP's. I understand that. So my understanding, OMPP doesn't have one of those. I get that. Right now, that 100 or 800 number is getting calls for TANF, SNAP, and PEBT. We haven't heard anything, and I think Tracy raised this in the questions. We haven't heard anything from the state agency about whether they intend to increase staff, whether they intend to appropriately train staff, whether they intend to make that information available, and how we respond to those, I think, is going to be where the rubber really meets the road. And I don't think we're there yet.
All right, absolutely. And I think we can all agree that communications is an evolving element. We usually find ourselves good at continuing to communicate with those that we've kind of already found, or that maybe already we're well connected, but getting to those folks that aren't well connected and finding ways to do that is always the struggle. Luckily, we have Erin with us, who's all about working with those people at the grassroots level. So Erin, what are your thoughts on communication? What's working? What isn't working?
So I actually really appreciated what Jennifer said about like trusting relationships. I think one of the things that we've learned primarily through Mothers on the Rise and working with the women returning to their home communities from the justice system is that there are a lot of really great resources out there, but having a relationship with someone who can, one, help you know that you need to prioritize this, and also walk you through, like, what is it going to be like when I go through this, or to answer questions. Like, having that relationship is really key. So I appreciate her point about really working to make sure that folks who are in those positions are equipped and ready to help people navigate. The other thought I had, we have an initiative through faith-based organizations, and they can be a really powerful vehicle for connecting people to resources as well. So kind of thinking creatively about where are places in the community that those trusted relationships already exist, and then working with those entities to really shore up their ability to connect people to these kinds of applications and supports.
Great. Andrew, anything to add or any unique maybe communications channels that you've uncovered working with your populations?
Sure. And one thing, very briefly, I'd like to address Sarah's question in the Q&A, asking about if there are groups that are addressing some of these health issues in housing. That is something that this Hoosier Housing Needs Coalition that we convene definitely looks to address. That there are policy issues there. I think that gets to a communications aspect as well. And I'd like to emphasize that as much as the type of people who are on this call that are staff with community-based organizations, that those folks can both help relay information on the front lines to the clients that they work with, but also help lift and educate policymakers up. And I think that's an area that there needs to be work, but it's also an area where I think that impact can really be felt. And you know, just as an example, this housing task force that I'm here today, some of the legislators that are convening it recognize that there's an issue with the lack of supply of affordable housing, but they may not have the right information yet about where that need is greatest. So for example, like we know that in Indiana, there's only 38 affordable and available units for every 100 extremely low income Hoosier households. And that's in the bottom third of the available rate in the Midwest. But you know, coming into this housing task force, legislators were talking about, well, no, that's more about, you know, those are social services people. We're talking about the workforce, people who are going to buy houses, new houses at $200,000 or more. And Jennifer, at a national level, that doesn't maybe sound like too much, but here in Indiana, there's a large percent of the population that's just not going to be able to buy a $200,000 home. So the more we can do to help inform them about where that need is, and to Sarah's question about where there are blockages in the pipeline. If there are people who are living in places that have pests and mold, there are not a lot of levers available to them to move up that housing pipeline so that they ever could buy a new home. So again, just re-emphasizing that as much as we can inform people about what's available, but you know, very briefly, IndianaHousingNow.org has some of the links to the remaining pandemic-related housing assistance that is available. We can inform our clients about those aspects and then make sure that we're informing policymakers about this. Those are two necessary steps.
Wonderful. So we're going to segue into more audience questions here in just a second, but I do want to see if Jennifer, if you have anything to add on really promising communication practices. I know you covered some in your presentation. Is there something new or emerging that seems to be really working or helping us locate some of those populations that we struggled to contact with before?
I think the two kind of emerging best practices are around text messaging. As I mentioned, that's a really great way to reach out to people, to connect with them. People's numbers change and stuff, but you know, even homeless individuals or you know, individuals in very unstable situations often can receive a text message, but not just, it's got to go beyond just sending it. It has to be have a call to action in it. So your renewal is due is one thing. Great, let's just cause panic. No, your renewal is due. Call this number, visit this website, connect to somebody. We need to make sure that that's done effectively. And I think the second thing here is this is a unique point where some of the messaging research is really essential. And we've got some great partners at GMMB, at Perry Dundam, who have done some research on how to communicate this. Because again, in many states, renewals have been happening throughout the pandemic. People got the notice, may have not responded, but kept getting Medicaid. So how do we communicate to them that something's new? We talk in terms of PHE. You obviously don't want to mention the PHE to folks because that makes no sense. The general public is not really tracking this the way some of us are. And so how do you say the rules have changed? This is what you have to do now. Watch for this. That combined with this 12-month period of how long it's going to take, make it difficult. So it's not just a matter of sending out a notice, sending out a text message. The content of it is very essential. It needs to be thought through, user tested, you know, engage all of you all as far as how does this resonate? How is this going to be heard by the population? And is it going to actually convey the message that it was intended to?
Right, that's excellent points, and I think we can all relate to maybe information that we get, especially via mail, where we're getting updates on, our insurance or our explanation of benefits or random things from our utility companies, and those nice 5-page long things that find a way to be very useful, recyclable materials very quickly. Right, so I think that's an important point to look at. How can we be succinct? How can we have specific calls to action? And how can we make it so it's something that actually captures attention, isn't seen like just another notification of something that seems a little bit too bureaucratic to pay attention to, right? If it doesn't work for folks not in these programs, and you're dealing with folks in these programs that have so many additional barriers going on and so many additional stressors going on, I think that's a very important point to look at and say we need to look at best ways to streamline. Instead of communicating everything, how do we communicate what's necessary? Very, very good questions there. Go over to our chapter a little while. We have some folks like jump right into some fun policy stuff, as I thought maybe we'd like some of them to do. So we have definitely some talking about the Healthy Indiana Plan specifically, and some of the things that go with that. So noting that when the public health emergency ends, it isn't just now, here comes time to do redeterminations and renew your coverage and all of that, but what about all these other things that are in there? Premiums, Healthy Indiana Plan, of course, has things like its power accounts for the different levels that you have there, the Children's Health Insurance Program. So what's our concern about the effect that all of those other elements are going to have that maybe our consumers haven't been indoctrinated on yet? I see several of you looking for time to think on that. So, but when we have these rules suddenly coming back into play, in addition to all the renewal stuff, what's your fear with your population of what the reactions could be with that? Maybe start with Erin.
Well, I haven't been at grassroots MCH long enough to kind of go through that, the HIP requirements, but certainly fear that people will get locked out of coverage or lose coverage. And one of the areas that I have spent quite a bit of time in, including with 2 grassroots leaders who are part of a team together, is focused on medical debt and the consequences of medical debt. So when people don't have coverage or have inadequate coverage. And that's one point I just want to take a minute and pause and emphasize that, not all coverage is great coverage. And certainly through Ask the Women, we've seen folks hit with some astronomical medical bills, even though they have insurance coverage. I wanted to bring that into the conversation. Medical debt's a huge issue in our state, and it has a lot of consequences for folks. One of our grassroots leaders just shared her experience of having medical debt from a baby in the NICU with the Indiana Capital Chronicle, and that was published yesterday, but essentially led to a tailspin of her losing her home and having to make really difficult decisions about whether or not to buy food or pay this bill, or becoming employed and then having wages garnished. And in Indiana, we don't have a lot of protection against wage garnishment, and that can be really punishing and really leave a family with very little. So that is one of the consequences I'm definitely worried about. It has, we've seen a lot of other states stepping up to the plate to pass legislation to at least insulate folks from the consequences of medical bills and medical debt. In our session is coming in January. We'll see if anything comes forward on that topic, but certainly there are things that can be done to ensure that folks receive charity care when they qualify, and are protected from having to pay ginormous amounts of their income toward debt. So we'll look for that.
Absolutely. So I think that's a good one for us to spend a little bit more time on too, is that medical debt, but then also the concept of how do we build wealth? How do we move people away from poverty when they've got some of these barriers in place and some of these things working against them? I know when we look at things like payday lending, medical debt is usually one of the top 1 or 2 declared reasons for having to take out those loans. And we know the negative cycle that comes with that. So Yeah. How does proper coverage really prevent folks, improper coverage prevent folks from lifting themselves out of some of those poverty cycles, and what can be done to combat that? I think is something that really crosses all of our paths here. And I don't know, Andrew, you're our expert on wealth building. Do you have anything to add to that part of the discussion?
Well, and actually, I know that Aaron has also worked on this type of work for many years, and so I think it's important to mention that you're right. People who get caught up in debt traps, like through payday lending, again, that is another wealth stripping exercise that can really take away their ability to pay for the basics that this group has already been talking about: the food and shelter and the health coverage that they need. There are proactive opportunities that are out there. There are some, match savings accounts, but that's not going to overcome the negative effects of something like payday lending. So we really need to see some strong limits at the state. The groups that we work with, another coalition we convened called Hoosiers for Responsible Lending, has been advocating for many years for a 36% cap on payday lending throughout the state at both the federal and the state level. We're also convening a third group called the Indiana Assets and Opportunities Network that is looking at more proactive ways to save and to be able to build assets. And we don't have a ton of time to go into all those different opportunities today. But one thing I would say is if people go to prosperityindiana.org and sign up, you can be added to each of those lists. So Aaron, I don't know if there's anything else specifically that you have in mind about the connection between payday lending and consumer protection.
Well, what you were just saying was actually making me want to, I was thinking of a story of one of our leaders who kind of dropped off that 60-day Medicaid postpartum cliff, ended up with a medical condition that required care, and then landed in medical debt that ultimately damaged her credit score. So I think there's that connection there to housing access and security when these bills are on your credit score. Thankfully, I think we're seeing some policy efforts nationally to erase that consequence. But it also made me want to give a shout out to the state of Indiana for their policy decision to go ahead and create that 12 months of continuous coverage postpartum, so that doesn't happen to folks, because it can be a really difficult and challenging time to be thinking about, where am I going to get coverage after the 60-day window ends.
Yeah, we're all very excited to see that one get through, and that's a huge deal, especially after giving birth. There's a lot of women that have a lot of struggles and a lot of financial barriers coming in, and then what feels like there's a system that's just kind of pulled out from under you when you really need to be accessing that care the most of anything. We're very, very excited to see that, and then that does give me a pause to ask the question too, when we're looking at health coverage and how important it is and how it flows through all of this. I'm wondering, and I'll get this one over to Emily, when you're talking to consumers though, because you work obviously with very clear basic needs of nutrition, where do you really think having health care coverage falls on their spectrum as far as what they're attending to? What's their focus right now today?
Sure. When we meet clients, we're looking at a basic need, right? So it's immediate, it's prompt. We've talked about, I talked to a lot of folks who, if you can't imagine what it would be like, think about it in terms as a natural disaster, right? If you have a hurricane, a flood, a tornado, you have an emergency right now. If you don't have any food in your refrigerator, you're also having an emergency right now. That's, and the ability to cope and the trauma that causes is really just immeasurable. And so, our first thing is to feed the line. Our members talk about we feed the line, we want to shorten the line, but we need to feed the line. And so we seek to, hit that immediate need. But we also know that hunger doesn't exist in a vacuum. If you are food insecure, at risk of hunger, you're also having more than likely issues with your rent, your utilities, your transportation costs, medical debt, prescription drug issues. All these things go together. And so we like to look at it from a holistic perspective as much as we can in the small touch points that we have with clients. We do have food banks that are looking more and more into how they can engage in client services. So some of our folks are doing SNAP outreach, the actual application assistance, but they're tying with that. Do we need to connect them to LIHEAP? Do we need to, see what Section 8 is available? Do we need to see if they're insured? And so a lot of places are looking into more of that where they have the capacity, and that's kind of the problem. And so in my mind, you could do it one of two ways. You could increase the capacity of case management that our folks have and contact, which is really hard to get folks to come back in. It's a lot. The other piece is, how do we best tie all those programs together so that, we have a bifurcated application between SNAP and TANF and Medicaid. We didn't used to. How can you get to the end of one and see a thing that says, click here to apply for the other thing, and have all your data merge, right? We have really great data transfers between agencies. SNAP is transferred to WIC, which has a different process. SNAP is transferred to to DOE for free and reduced lunch. We have these great data matches. The White House Conference on Hunger talked about how we could do more of them and how we could make that more interconnected. But if we can, behind the scenes, start doing that data match to say, okay, so you're getting SNAP, or you're on WIC, or you're getting TANF. In no world should you not be connected to health insurance. There's no way you wouldn't be eligible for assistance. How do we close that gap? And I think to do it more simply for the client, rather than requiring the client to engage that extra step, would be sort of the perfect scenario. I realize that's what everybody would like to do. And it's easier said than done. I will say our state does a good job at connecting dots where they can. And sometimes you don't have apples to apples in eligibility. That'd be another great thing to fix. We've got different eligibility guidelines for different things. Don't necessarily have to. We've seen states who have raised eligibility for SNAP, who've raised eligibility for TFAP, which is on our end. But there are things that we could do that we wouldn't even have to make the client panic and freak out about recertification and submitting documents and all these things. I think that's, in theory, an easier fix than trying to talk to every single client who comes through the line to make sure that someone on staff knows enough about Medicaid, about TANF, about SNAP, about WIC, to help them to the point that we get them connected. So not a good answer. I think there's a couple ways to look at it. I think the easiest answer is to just make it happen. But you've got to have the technology and the investment in that technology, and then a little bit of political will to make that happen.
Right. Absolutely makes sense when we've got families that are trying to sort out so many systems all at once. What can we do to do that sorting for them? And so they don't have to, have 6 different things to apply for, and rightfully so, probably run out of steam after just getting on 1 or 2 of them. I can't blame them for that process. So let's talk a little bit more about the streamlining. I do want to bounce back to Jennifer a little bit, especially after Emily's comments on getting SNAP and Medicaid to play nicely together. What are we seeing? What's the national movement going there? And how well is it going so far? I know it's a big push.
It's really challenging, and the good news is that there are solutions for every state, whether your systems are separate or together, whether applications are separate or together. We've been lucky enough to partner with Code for America, a civic tech firm out in California that's been doing a lot of work to try to streamline benefits and improve systems. And it's a tough nut to crack. There's no doubt about that. The good news is that the policies are very complex and differ. And I don't think it's realistic that we're going to get the household and income definitions to align among programs. That's not likely in the cards in the near future. But there are all these linkages, all these points of connections where you can use one program for eligibility for another. And SNAP is often considered the gold standard because of how often it is reviewed, how thoroughly income is verified. And so there are ways to, I mentioned using SNAP information at Medicaid renewal, but there are ways to enroll people on the front end in Medicaid based on their SNAP enrollment. And some states have explored things like a checkbox, where on one application, if you put, I'm interested in WIC, I'm interested in Medicaid or SNAP, that initiates an application for the program. And in SNAP, you can gather the additional information required through an interview. Or in a program like WIC, you've got the derivative eligibility that because you're enrolled or SNAP or Medicaid, you're automatically financially eligible for WIC. So there are ways to do this on the back end, but it does take a commitment, and it does take a consumer-facing application that is user-centered and does make it easy to enroll in these programs, because there's absolutely no reason to re-enter basic information about name and household members and birth dates and all this stuff. The technology is out there. It's the will to do it. I mean, you look at the complexity of systems that other industries have. So it is very much possible, and especially with, as I understand, kind of a joint back-end system that you guys have, you don't have the same barriers that others face. I look again to Code for America's demonstration in Michigan. They had a joint SNAP Medicaid application, a full application, not name, address, signature for SNAP, not cutting corners, that took 10 minutes on average to complete. It was the full single streamlined application for Medicaid. It was a full SNAP application. So it's possible. And we have these great partners in the nonprofit civic tech world who are willing to come in and help. We have vendor limitations and other complications where even if they have the answers, sometimes it can't be done. But I think it's really worth looking at application, but also for ongoing case management. We see you are enrolled in this program. Are you interested in WIC? Are you interested in SNAP? And how do we make those linkages? So lots of opportunities, both in the policy space and the technical space. We just got to kind of bring them together and have a state prioritize it, which is very difficult when they're trying to keep their head above water with their kind of day-to-day operations. But if they prioritize it, it can be done.
All right, well, let's just do that. I don't know if we can just get the crowd to vote on it, but that sounds like the way to go, right? So, but it's good to know that there are models that are emerging, they're still being refined, and every state is different, but that's in a lot of ways, it seems like it'd make a lot of the administrative burden go down if we can make that initial investment and make those shifts as well. So it's kind of a win on all fronts. So I'm going to go to a slightly different issue right now. We've got a couple of questions that have come in on maternal and child health specifically. Of course, Medicaid, we know, has a massive role in that. So Indiana, during our special session over the summer, passed some legislation that, among other things, put in a $45 million allocation through a set of funds that can be used towards improving maternal and child health outcomes, pregnancy outcomes, et cetera. So I'd love to go through our panel a little bit. Talk about what is maybe one tangible thing that you could see that 45 million being good for. And then if we're treating that as a down payment for a bigger promise, what's really needed to tackle maternal and child health on a broader space than that? And we have one person that has maternal and child health in their title, so I will start with Erin on that one. She doesn't get away too easy.
All right. Yes, actually, I feel well prepared for this since I went and testified on the $45 million allocation, which feels a little bit like a drop in the bucket of what we could spend to support our moms and babies here in Indiana. And one of the things that I wanted to raise awareness of for our legislators is, coming from our Ask the Women project, just how disruptive to someone's financial situation a pregnancy can be, both in their earning potential. So seeing women pushed out of the workplace because of things like severe morning sickness, or being fired for attending too many prenatal visits, or naturally, having to take some kind of leave to give birth and to recover from childbirth, often not nearly long enough. Hearing stories of folks going back to work 3, 4, 5 days after giving birth, sometimes to very physically demanding jobs. So I have long been a strong proponent of some form of paid leave or financial support for, a pregnancy medical leave and that postpartum period. And I think that would go a long way to stabilizing households who are going through a pregnancy. But if we're not going to do that, we've talked a lot about housing stability and the effects of housing on birth outcomes. So a program like Healthy Beginnings at Home and subsidizing some of those housing costs would be another way to kind of, allocate some of that spending. I worry about the medical costs for folks who are uninsured or underinsured related to pregnancy. We're hearing about bills, in the tens of thousands. We know mental health is an important and under-resourced area for our pregnant women and new moms. And then also I would see, like, you got me into my whole wish list. This is like, you're getting the whole list. We also have grassroots leaders who are very passionate and very strongly believing in sex education and starting early. Like, that is really our first opportunity to promote a healthy pregnancy, right? At least to provide that education. And so investing in that would be another welcome area. And then finally, I'll say we asked a really cool question in our Ask the Women interviews toward the end. One of our grassroots leaders suggested, like, why don't we ask people, if you could imagine a place in your community that was really supportive to pregnant individuals and new parents, what would it have? What would that look like? And now we have this amazing list of everything from aromatherapy and cooking classes to like trauma support and, attorneys who can assist with domestic violence situations, like a whole gamut of things that folks feel are missing in their community and really would be a welcome support during that really important time in a family's life and development. So there's my huge, I'm sure I've missed a whole bunch of things. Like, we could just keep going for another hour and we could come up with ways that we could spend money to better support families. But I will say one more thing, like, I'll go back to the point that I made earlier, that sometimes, like, spending the money here can save us over here. So it's not just that we want to explode the budget, but let's spend smart in ways that cut down on things like NICU stays and other like expensive healthcare costs that we're going to end up paying for down the road.
A very important point is prevention always pays for itself, right? We know that's been proven. So I think that's important when we talk about making investments, to realize that sometimes investments actually get a repayment on them, right? So, all right, we have some questions as we're talking about that 45 million. We have some questions related to housing specifically too. So maybe I'll push over to Andrew on that, talking about the question we have is talking about building relationships to purchase and rehab existing buildings into affordable housing, specifically in rural areas. So I'd love to hear about relationships like that and other things that this wondrous $45 million can do for housing, Andrew, and maybe a little bit of what's your wish list for what more could be done beyond that.
Sure. And I guess let me say that, I think we are at this interesting opportunity again, here today because of this housing task force. I've heard some rumors that this next session that with the State General Assembly will be a housing session. So we really want to, capture that opportunity as much as we can and make sure that we're bringing the voices of the people who are most impacted and the organizations who serve them into that discussion. And so at a very high level, I think that we're going to be trying to remind our policymakers that in order to make a difference on affordable housing for the people who need it, we need to increase the supply, make that supply more accessible to the populations who need it the most. And then third, increase habitability standards so that everyone can have a safe and stable and affordable place to live. So in that 45, the magic 45 that's out there, I think there are opportunities to be able to increase the ability for nonprofit organizations to be able to help participate in providing more affordable housing. But, in the bigger picture, I think that amount's not going to make enough of a dent on its own. So one of the big pieces we're looking at, and thinking back about the question we saw from Sarah earlier, in terms of families that are dealing with really unhealthy living conditions. We get these questions all the time: black mold and raw wiring hanging from the ceiling. Indiana right now is one of only 5 states that does not allow tenants who are facing those kinds of serious health and safety violations to either be able to put their rent into escrow with a bank until those problems are fixed by the provider, or to be able to get in there and fix the problems themselves and deduct the cost from rent. So, I think that that's one part of the equation about why our housing supply for the lowest income households is so low, is that we frankly incentivize some of the worst actor landlords to be able to, not maintain places, and there's no teeth in pre-existing health code and habitability enforcement laws. So that's one thing that we're planning to really look at this next year is that ability to be able to put rent into escrow or to repair and deduct yourself. So we'd love to have people on this call be able to help inform those discussions. There's some issues at the federal level, some that are currently in discussion that would help increase the supply of affordable housing and that would help create a permanent emergency rental assistance program. In fact, that's what I was doing earlier this week, was at a national convening about how to help shape what a program like that might look like. And again, what we really need is to get the voices of people who are working with these populations to be part of those conversations. So if I had one major request from people on this call, it would be to be part of that conversation, help us elevate the stories of the people you work with to our state and our federal legislature.
Excellent. All right, Emily, it's up to you. $45 million, what can completely be solved with that amount of funding? And how much more would you want if you really wanted to get crazy and fix some bigger things?
So you're asking an advocate to spend money and how I want to spend money. This is all our sweet spot, right? So I will start with at the end of this last General Assembly session, the General Assembly eliminated the possibility for SNAP emergency allotments, which was bringing in at that time an extra $50 million a month. So this gives you some scale. There's lots of things. I mean, I can throw money at things and, find ways for it to be used. My best thought on this for that small amount, and I'm looking at the nutrition part of it. Okay, that's my background. I would go with take that money and either invest in the DFR call center and find a way to combine that with 211 for better integrated services so there's no wrong door to get information and access. Or the other piece to that is to work on WIC. So Women, Infant, and Children is a program that is addressing pregnant women, breastfeeding women, small children. Our program did a lot of great things during the pandemic to make the program more accessible. We were one of the early adapters for EBT. This is all great. If we could move things to an online purchase, which I know that they're thinking about, and there's logistics to that. If parents are out there looking for formula, you're going to be doing a lot of looking if you have to go store to store to store. If you can find it online and use your WIC account to purchase it and get it to you, I think that would move mountains. Making those improvements to the program, which I would add currently, we're the only state in the country where you must attest to your U.S. citizenship to apply, even if you are an 18-year-old who is pregnant and will be giving birth to a child in this state. So that's a whole other issue we're working on. But making sure that WIC access is there so that when mothers are pregnant, when babies are born, they have access to nutrition. It's a tailored program, so it's not just going out and buying what they would want for their household, for better or for worse, but it's providing the specific items that they need based upon their dietary risks, their age, and what's going on between the mom and the child. But it's a significant provider of formula across the country, and so to be able to better find what families need, I think would make a tremendous difference. Find and afford would make a tremendous difference toward maternal and child health. And I think you could probably get that done with $45 million, or I know the USDA has some grant funding available to start attacking the same sort of thing. So one way or another, we're having these conversations. I could take that $45 million, I could take the Fed's $45 million, either way, but we'd be happy to start pushing the needle on that.
All right, sounds like we got lots of places for the money, and 45 million maybe is a small down payment for some much bigger things. I will say, by the way, I can just take 5 of that to finish up with the 5-year immigrant rule. So see Mark actually had something that fit within that budget. So there we go, problem solved. Okay, we're already getting so close to the end of our time. It really flies when we've got so many good policy wonks in the room here together. I did want to give Jennifer a chance to respond a little bit, though. Do you, Jennifer, have a national wish list item if you were to pick out one item that you'd really love to see change? So snap your fingers tomorrow. We took care of this one.
I'm going to reveal my wonkiness, which I probably have not been hiding throughout this conversation. But you know, it's not a money issue, it's the renewals. It's the ex parte renewals. That is, you know, I started out as a food stamp caseworker way back in the day, oversaw SNAP for Illinois for a number of years. When you come from the SNAP perspective, and there's this way to automatically renew people using data sources and not requiring anything from the client, that is such a huge opportunity. And some states are really underutilizing it. We talked that I think Indiana's doing a great job there, which is amazing, but there are states that have not implemented yet, or are doing it for less than 10% of the population. And so we look at administrative burden on clients. When we look at churn, when we look at the burden on a state workforce of taking on all of these renewals on top of SNAP and on top of everything else they're dealing with, why don't we do this? And it's a positive for program integrity as well. You're using very reliable electronic data sources to confirm ongoing eligibility. So if I have a wish list, if I had a magic wand, that would be the one thing that I would see maximized, would want to see maximized across states.
Excellent. All right. Well, again, just a couple minutes left, but I do want to leave with making sure our audience has some good action steps they can take. So I want to go around to our panel and also say, what can anybody, regardless who they are, where they're coming from on this call, what can somebody do to start getting one or all of these things moving along? Erin, what do you have to say to the audience on that?
Well, Mark, I'm really excited about your presentation at the commission yesterday to kind of remove that barrier for children and pregnant individuals who are lawfully residing residents. So I think whatever Mark tells you to do, you should do. And I guess we'd love for folks to stay connected to the Grassroots MCH initiative. So a really quick and easy thing they can do is follow us on social media or sign up, and we'd love to partner with, you know, the amazing people on this call as we move forward and trying to promote maternal and child health in Indiana.
Okay. Andrew, how can people get involved?
Well, I've mentioned this a few times, but again, you know, what we really love to see is people be part of this conversation on the housing side, and also on that asset building and consumer protection side. Easiest way to do that is to go to prosperityindiana.org, and then there's a subscribe button at the bottom, and choose the items that you're most interested in. Love to have you on our big list about community economic development, but the Hoosier Housing Needs Coalition, Hoosiers for Responsible Lending, and Indiana Assets and Opportunities Network. That's one place you can keep up on all that. And again, I'd be remiss if I didn't mention the Indiana Coalition for Human Services at ICHSonline.org. And that is another way to be part of the broader conversation and to join folks like Mark and Emily and myself as we're trying to take this on at the big picture at the state level.
Great. Emily, what do you got for us?
So I would sort of echo other comments made. We are in the process of launching the Indiana Hunger Coalition with the Indiana Community Action Poverty Institute. Two of the folks on this panel were former employees thereof, and we are great partners of theirs. Working on state and federal anti-hunger issues, I think the easiest way to keep an eye out for that would be to follow us on social media. So it's Feeding Indiana's Hungry on Facebook, and our Twitter account is Feeding INS Hungry. As you will see more information coming out about that and about things that are going on during session. We're expecting to have a lot of conversations about some great policy initiatives, maybe have to defend against some not so great policy initiatives. And so, you know, I mentioned that royal we, and I think it's done without coalitions, ICHS, housing, all these other things. So making sure that you or your organization is tuned in and is aware and can chime in as to how these things would impact you and your clients is a tremendous help.
Wonderful. Okay, last but certainly not least, Jennifer, any parting words of encouragement for our audience?
There was a panel earlier this week where a Medicaid director from Hawaii asked the audience, does anybody in the audience know somebody on Medicaid? And the vast majority of folks raised their hand. And I know that many of you who do direct service in the audience know many folks on Medicaid. So just engage in this, get the information, help people get the word out about what's coming. But most importantly, don't accept that coverage loss is inevitable. Don't accept 6-hour wait times at a call center or people doing everything they're supposed to, but still losing coverage and experience a gap in coverage. We can do better. There are solutions out there, and we should hold states across the country accountable for implementing these solutions to protect folks. And if anybody wants to walk out on some of these issues around tech, policy, operations, please do not hesitate to reach out to us. We've got a great project, Elevating the Medicaid Enrollment Experience, which is supporting advocates across the country on some of these administrative advocacy issues and things that affect the folks who are actually engaging in these programs. So we are available and happy to help in any way we can.
Great. Well, I have to just stop now because unfortunately we're at the end of our time, but I can't thank our panel enough. Aaron, Andrew, and Emily, wonderful state level leaders that are doing so much good stuff. Jennifer, thank you so much for joining us and providing all this information. For all of our attendees, do note there'll be a recording sent out of this. So if there's anything you missed or you're trying to scribble it down, we will have that available on our website and send that out to attendees. We really want to thank our audience most of all for being here because you are the folks that are going to make a difference, and we hope we've been able to empower you. You can link up with any or all of us. I think we all have plenty of work we wouldn't mind some extra help with to be involved there. So thank you for those who've been able to join us. We do have going into the chat, there'll be a link for a survey. This will also be the one that generates the CEUs for you. If you want those professional CEUs, but please take the survey, give a list of things we should be working on, or as Aaron volunteered, anything that you want to be doing with Mark and get accomplished in the state. But I may field that out to some of our other partners as well, because there's always more that can be done. So ways that can be done for covering kids and families specifically, sharing, we do have a policy and provider committee, meets year round. This, if you really want to get into doing things specific with State House activities and active involvement there, we encourage you to contact me, get involved with that. Of course, they also plan this summit, so we're already going to start working on next year's topics. And as Andrew mentioned, if you're an organization looking for a place to get involved, that's a great way to plug into policy, the Indiana Coalition for Human Services. We need all the voices we can on that, all the organizational leadership we can get, and it does a phenomenal job educating leaders in the policy space, and then making sure that we all get involved and do wonderful things. So thanks again to our audience for joining us. Thanks so much for our panel and Jennifer for being here today. We look forward to hopefully seeing and hearing from a lot of you throughout this year and at next year's Policy Summit. Thank you all.